So in extended clinical, for the first 5 minutes, what do? Candidate and invigilator will enter the station. Candidate reads the candidate information sheet, reviews any audio, video, or photo universal cues. So along with the information sheet, you will be given some audio or video or photos, whatever. You will see that. At 4 minutes, the invigilator confirms the candidate has read info sheet and reviewed any cues. So there is only 4 minute time to read the sheet and to hear to any audio, watch the video or see the photo. Examiner and role player enter station while candidate is reading and mute themselves. So they will enter the station, both examiner and role player. Invigilator announces the station has started. And in this time, the examination introduces himself and the role player. Examiner provides introductory statement to you. Okay. This is in the first 5 minutes. As soon as they say that the station has started, for the 10 minutes, you will be given the time 10 minutes for history taking. So examiner asks candidates to take focused history. Candidates takes focused history from the role player. At 6 minutes, invigilator announces you have 4 minutes left to gather your history. So there will be a warning bell, or they will tell you that 4 minutes left to collect your history. At 10 minutes, invigilator asks candidates to stop taking the history. So maximum is 10 minutes, you will stop taking history. Then for 2 minutes, examiner asks candidates to briefly summarize key findings from the history. So 2 minutes is for summary. Then after 2 minutes, examiner asks candidate to describe step-by-step process to how they would undertake an examination. So you will be given a particular system like cardiovascular system or respiratory system, and you will be asked to tell the step-by-step process of how you would undertake the that system examination in this patient. Candidate describes the examination process. Examiner provides dependent cues to candidate during the candidate's description process. Okay. The candidate keep on telling that he wants to check, for example, look into the eyes for pallor, or he wants to auscultate the chest. So examiner will give you when you want to auscultate, he will give you the findings. Okay, once he gives you the findings, finally you have to interpret the signs and also should come to the diagnosis. So this is for 8 minutes. Okay, in that also after the examiner asks the candidates to describe step-by-step process of how they would undertake the examination. This is one thing. Then the candidates describes the examination process. Examiner provides dependent cues to the candidate during the candidate's description process. For example, if you say that I want to auscultate the chest, he will give you the findings on auscultation of chest. So examiner asks candidate to briefly summarize the clinical signs they have elicited. All these summary will take place in these 8 minutes only, and there won't be any warning bell here. Candidate briefly summarizes the clinical signs. Examiner asks the candidates to interpret the signs and what they mean. Candidate provides their interpretation of signs and meanings. Next is examiner asks candidate questions relating to the D1 domain. Okay. Which will vary depending upon the specific focus of the scenario. Candidates response to the questions. Examiner asks candidates questions relating to D2 domain. Maybe these are the things. This is D1 and this is D2. We will go through it, which will vary depending upon the specific focus of the scenario and candidates response to the questions. Invigilator wants 3 minutes left. At 23 minutes, invigilator announces the station is over and asks everyone to remain in the station until told to move on. So this is first 5 minutes, then 10 minutes, the history taking, 2 minutes summarizing the history. 8 minutes for examination and interpretation of the skills, and 3 minutes for the discussion. So what is D1 and D2? D1 is formulates and proposes likely appropriate differential diagnosis. So at the end of 8 minutes, your examination is seen and questioned. Then at the end of 8 minutes, when 3 minutes left over, you will be asked about the differential diagnosis. Understand the implications of the findings, able to suggest appropriate steps if exam is inconclusive. So you will give the differential diagnosis and you will give reasoning for why you want to give this as your differential diagnosis as the top. And also if you want to do anything else to prove your diagnosis. So D2 is management planning, relevant investigations to appropriately address the identified problems, provides safe, ethical, and effective management plan that relates to role player concerns, including appropriate referral and escalation. So in the management planning, you will tell about what investigations you want to carry out in this patient, and also the safe, ethical, and effective management plan that relates to the role player concerns, including the appropriate referral or escalation. So if you want to refer also, you can tell here. Then the communications, even communication skills rapport, appropriate level of confidence, greeting, introduction, professional, sensitive, appropriate body language, response to verbal and non-verbal cues, develops appropriate rapport with the role player and puts at ease. Okay, clarifies role and shared agenda, appropriate tone and pace. So here you will be always, this covers all over the station, your communication skills, rapport, empathy, sympathy, everything should be all over the station. Next, we'll go for what is A, B, and C. In A, when you will be given time to take the history, so what you should do? Ask key relevant questions, sensitively gathers appropriate information, or you should take the focused history which is most relevant. Explore main problems and concerns of the role player in structured manner. Chief complaint and the concerns is very important. Then in physical examination, well-structured systemic exam technique verbalized, appropriate recognition of requirement of care taken to adopt the needs of the patient, including permission to examine, is sought out. So you should also tell the structured examination, and even the permission to examine has to be, but there won't be any patient. Maybe we have to just inform that before examining the patient, we'll take permission from the patient or the parents. Appropriate use of equipments or development toys if relevant. If needed, you will use any equipment. Then C, identification of clinical signs. Identifies clinical signs that are present, correctly interprets the clinical signs that are present. Okay. So anyone wants to comment on this? I want to ask about this. We will tell to the examiner that we will take the permission from the patient, or what?
Yeah, like exposure thing. Second one is for like abdominal examination, any pain, or MSK, any pain. These are all should be like, no, we shouldn't know before examining. And permission definitely will take from the parents.
So here now, this is a situation where there is no patient. So we will just tell the examiner that we will be taking the permission from the patient.
Yeah, like physical examination, they will tell, no? So we will tell that I will make rapport with the mother and take permission for the examination. Then I will do my hand hygiene and go to the child and make rapport with the child. Like this, we will start.
Okay. Okay, I will give you the case now
Okay.
and then 5 minutes. Okay. So now I am starting 5 minutes time and I will give you the case. Okay.
Okay.
James is 2 days old child. He has been brought by his mother because he is not taking feeds and he looks pale.
Okay.
Okay. His vitals are heart rate 160 per minute, respiratory rate 60 per minute, blood pressure 70/40, and SpO2 89% in room air. Okay. During discussion with the examiner, your approach will be tested for cardiovascular examination.
Okay.
Okay.
What is the mother? Okay, no need for
Mother is,
mother's name.
yeah, you have to take. Mother is Christy.
Christy. Okay. Okay, I'll take 2 minutes, then we will start.
Okay,
Okay.
no problem. Okay, both Ola and Sridevi, you can start. Huh?
Okay. Good evening.
Good evening.
I'm Dr. Sridevi, one of the baby doctor here. I believe I'm talking to Christy, mother of James.
Yes, doctor, this is me.
Yeah, nice to meet you and thank you for coming here to discuss about James. So I will discuss about James and make a note of it. Is it okay with you?
Yes, doctor, no problem.
Okay, first of all, congratulations for your newborn baby,
Thank you,
birth of
doctor.
James. Yeah. Okay, so can you tell me what is your main concern about James?
Actually, James was born yesterday morning. He is
Okay.
fine. He was fine. And I was very happy. They did not keep us for a long time. They said the baby is normal. You can go home. I went home. He was fine overnight. But
Okay.
today evening, he's not taking his feeds. He has started refusing to take his feeds. And I thought I was just breastfeeding. So I thought I will try bottle for him, but he's not taking that also. Now I feel my baby is pale, so I brought him to the hospital.
Okay. So, Christy, can you tell me more about like these before, like after birth, baby was feeding, and since when baby stopped feeding well?
As I told you, second day, today is the second day, and from evening today.
Okay, today itself. Okay. Anything else other than this you have noticed
I
with
feel that
James?
he is not that active like before, like moving his hands, it's reduced. And also, the doctors were telling his oxygen is low. So I'm worried.
Yes. Okay. So, other than this, whether he's having any other like fever,
No
any,
fever, doctor, but I feel that he's breathing fast. His breath is fast.
okay, okay, and um, okay, any cough he has other than this? He has
No,
breathing.
no cough.
Okay. And any other issue you have noticed other than this?
Only he has this fast breath, and this only. He's pale and not
Okay.
feeding. This is the only
Okay. Any
thing.
bluish discoloration you have
No,
noticed
I
in
did
the
not see him blue, but
okay.
I can say he's pale. He's not pink.
Okay. When you see his chest, have you seen any uh, like no any abnormalities you have found by looking at his chest? You feel
No,
something?
doctor, I don't notice any abnormalities, but I see that
Mm.
I can see he's taking breath in and out. I asked the
Mhm.
doctors, this is because he's making the efforts, they told me.
Any okay. Yeah. Okay. What about his poo and pee?
It was fine. Yesterday he passed two
Mm-hmm.
times,
Mm-hmm.
and today morning also once he passed. It's fine.
Okay. Any sweating you have noticed while feeding?
No, I did not notice the sweating.
Okay. Any nasal congestion, nose block?
No, there is no nasal block, doctor.
Okay. Any skin rash?
No rash in the skin.
Okay. Anywhere swelling you have noticed?
No, no swelling.
Okay. Can you tell me about your during the birth and before birth history? Anything significant histories there? Like in first 9 months when you were carrying, any problem you had?
No. When I was 36 weeks,
Mm-hmm.
nearing to delivery, once I went for the scanning and they said that his heart rate was fast. I was a
Okay.
bit worried, and then they told they need to give some fluids for me. And after they give the fluids, they again checked and they said his heart is fine and they discharged. This is what. Otherwise, throughout my pregnancy, they were always telling the scan is normal and he's fine.
Okay. Okay. And after birth also you told me like they discharged within a day and everything was fine,
Yeah,
right?
and even some doctor also examined him, and he
Mm-hmm.
told he's fine.
Okay. So you didn't took any medications or you had any fever, blood pressure, no other issues during the pregnancy, any
Mm,
diabetes,
no,
like
no,
high
doctor.
sugar. Okay.
No.
Okay. Okay. How many children you have?
I uh, I have two children. The elder one is 2 years old now.
Okay. Okay. And he's fine.
Yeah, no problem.
Okay. Anyone has like similar problem means any
4
other
minutes.
problems? significant problems in the family?
No
Any,
significant problems, doctor.
okay, any heart disease or any other diseases?
No one has any complaint like this in our family.
Okay, okay, okay. So about shots at birth, any shots they have given?
No shots, but they told this, they just told me they gave vitamin K. That's it.
Okay. Mhm. Okay, and then how you are coping with this illness, Mrs. Christie?
No, I was nothing. This is the first time it happened, and I brought him here because he's just 2 days old.
Okay.
And I am now worried only like what is his exact problem.
Yeah, it's difficult time. I can understand that. Okay, so any financial issues you have?
No, doctor,
Okay,
we are
and
fine.
okay, good. And you and your partner, you are all staying together.
Yes, we are staying together.
Okay, now anyone is there to take care of you, to help you, because just now you delivered.
No, my husband itself is taking care, doctor. No one is there. And for my elder one, sometimes I leave in the nursery. If I am too much busy and I can't take of her, I sometimes drop her in the nursery.
Okay, okay. So, Mrs. Christie, do you want to add anything which I have not asked to you
I think
regarding
no.
gyms?
Everything went well. Only today evening this happened. Not taking feeds and he's pale, and I want to evaluate. There's nothing else I can add for you.
Okay, okay. So,
Okay, 1 minute 50
anything?
seconds.
Yeah,
Okay.
still left time, no?
Yeah, it's okay. If you don't have questions, you can continue with the clinical examination.
No, first I need to summarize, right?
Yeah, you can summarize now. I will.
Okay.
Okay.
So today I took history about James, who is 2 days old, from Mother Christie. The chief complaint is he's not taking feed since today evening, and he's becoming pale. And a mother has noticed there is fast breathing in the child, and his activity also reduced. And he was born yesterday yesterday, and he was well, and he was discharged also after 24 hours. And otherwise there is no significant history, any family history or any social history in the child. And antenatally also, all the scans, everything was normal. Once only mother required IV fluid. Other than that, there is no significant history.
Okay. So we will proceed with the examination now. Okay. I will set
Okay.
8 minutes for you. Okay. Can you tell about the step-by-step examination? How do you do in this child? Cardiovascular.
Cardiovascular. Okay. So first of all, I will take permission from the mother and do my hand hygiene and go to the baby, and I will observe the child, and I will look for the first, already child is in distress, and I would like to know about his weight and height and head circumference.
Okay. His weight is 3.75 kg. Length
Okay.
is 50 centimeters.
Okay.
Head circumference, now we did not measure.
Okay.
What else you want to ask?
I would like to ask about any any monitor attached, any IV cannula, anything, any
Yes,
special surrounding.
he is on IV cannulation and monitor is attached. And
Okay.
already your saturation is given for you. SpO2
Yeah,
is
89%. Yes.
yeah.
And what about any dysmorphic features I can notice?
No dysmorphic features.
Okay, then I will go to the examination of the hand. I will see for any cyanosis, any pallor, any throbbing anywhere on day 2 may not develop.
The baby is overall looking pale, including the hands.
Okay, okay, no signs of any actually infective endocarditis, right? Like any splinter hemorrhage, Janway lesions.
No, we don't see any
Okay.
signs of,
Okay, then I will check for the pulse. To look for the rate, rhythm, character, any radio-radial delay or radio-femoral delay. So I would like to check all the pulses.
Okay, so his pulse is 150 per minute. Okay, you can palpate it in the upper limb, that is the brachial pulse, but the femoral pulse is difficult to feel.
Okay, okay. Okay, then I would like to check the actual blood pressure. I got the upper limb, but I would like to check the all four blood pressure at the end of my examination. Then I will move to the head to look for any pallor, or any
Yeah,
jaundice
he
in
is
the
pale.
eyes.
He is
Okay,
pale.
okay.
Eyes
Then I
also
will.
is pallor.
Okay. Then in the mouth, I would like to check the central cyanosis, any high arched palate,
No
any
central
significant finding.
cyanosis, no high arched palate.
Okay. Okay, then I will check the chest. Neck is very short, so we cannot see anything. So I will go directly to the chest to look for any chest deformity, any visible pulsation, any scar mark. Very unlikely for two baby.
Chest for the go one by one. Wait, you
Okay.
will be asking the examiner so slowly.
Okay.
So
So any
chest, there is
deformity?
no deformity, no asymmetry. What else you want to ask?
Any visible pulsation?
No visible pulsation.
Okay. And then any scar mark and
No scar
any
mark.
okay, any retractions like intercostal retractions, subcostal
Yes, there
retractions,
are subcostal
suprasternal.
and intercostal retractions are there.
Okay.
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 So inspection.
Yeah. Then I will check for the cardiac apex. I will put both my hand on the chest, both right and left, to look for the apex. Where it is?
You can feel the apical pulse on the left side. So can you tell me how do you locate for this pulse?
I would put my palm on the left side, on the right side actually, and I would try to feel the pulsation.
Left
With
side or
the
right side? Both the sides you will put.
both the
And
side. I will check both the
okay.
side. Yeah. And
So
wherever
if
I'll get
you
the
felt the
maximum
pulsation,
pulsation, then I will with the fingertip I will check. Yeah.
okay.
After
So
checking with the palm.
it is in the fifth intercostal space, mid clavicular line.
Okay. Okay, then I will check all the pulsation in the upper right sternal area, upper left sternal area, lower left sternal area, and in the apical area for any thrill, pulsation, and also the parasternal heave. Anything I can feel on palpation?
No thrills. You cannot feel any thrills.
Okay, then I will like to auscultate in same all four areas. So can I get any murmur or any? I would like to
Yes,
check the
yes. Yes,
yeah,
in the upper left sternal edge, you can feel the murmur.
upper left sternal edge. Okay,
Yes,
exactly second, third, or fourth.
second intercostal space.
Left second intercostal space. Okay.
Any
Okay.
you want to check
Any?
for anywhere else?
Yeah. Yeah, murmur, I would like to check actually S1, S2 sound also, first and second heart sound, and also any radiation to the mainly any changes with the respiration inspiration and expiration. Maybe it is difficult with this rate. Yeah.
Okay, then what else you want
Then,
to?
yeah, and also I would like to check the radiation to the neck.
Okay, it's not radiated to the neck.
But it is in left second only, right? Okay.
Okay, yes.
Yeah. Okay. Then after this, I would like to auscultate the chest for any adventitious sounds, mainly breath sound in the anteriorly in the axillary area, and also in the back to look for
You
the
could not
murmur.
hear
And
any sounds in the lungs. It's normal.
okay, back also it is normal.
Yeah.
Okay, and no. Okay, I cannot see anything. No, in the spinal area, no deformities, nothing while looking at the back.
No, there is no deformities.
Okay, then I would like to check the abdomen to look for any hepatomegaly and
Yes,
splenomegaly.
liver is palpable 3 centimeters below the costal margin.
Okay, and what is the span and consistency and
Span
edge?
is 6 centimeters.
Consistency?
Firm.
Form and consistency. Okay. No, spleen is not palpable.
No, why you want to check for spleen in cardio station?
Mainly for infective endocarditis only we see, not for other cases.
Okay.
Then femoral.
Your
I would
time
like to check
finish,
the
8
femoral.
minutes.
Yeah.
8
Yeah,
minutes finish. Okay,
Okay.
so you can
8 minutes finished. Okay. So
yeah,
today I
8
examined.
clinical examination.
Okay, today I examined James, 2 days old baby who looks well grown for his age. Weight is 3.75 kg, length is 50 centimeter. He's having an IV cannula and also he's on monitor. There is no dysmorphic features and he is vitals are 160 per minute heart rate. Respiration rate is 60 per minute, blood pressure 70 per minute, 70/40, saturation 89%. And on examination, cardiovascular examination, I found he looks pale, and there is and chest examination. The apex is in 5th intercostal space in the mid-clavicular line, and there is a murmur, systolic murmur, which is audible in the left second intercostal space.
Okay.
And there is also a liver which is 3 centimeter below the right costal margin and with a span of 6 centimeter and form in consistency. And in in the pulsation, the femorals are not palpable. And in order to complete my examination, I would like to do the 4-limb saturation and 4-limb blood pressure measurement for this child.
Okay, so what is your differential diagnosis for this child?
My differential diagnosis is first is sepsis. Second is maybe a case of congenital heart disease because femorals are not palpable, so could be coarctation of aorta.
So your first differential is sepsis, second is congenital heart disease.
Yeah, with
Third is
coarctation of aorta. Third could be underlying some respiratory infections like pneumonia or something, but respiratory no findings in this, only tachypnea
okay.
and retractions
Anything
is there.
else you want to give?
And other possibility, I would like to maybe some metabolic disorder which can present at this with this tachypnea.
Okay. Inborn errors of metabolism.
Inborn errors of metabolism. Yeah.
Okay. So if this was coarctation of aorta, then how can you explain the presentation on this day, on the second day? What's the cause?
Okay, it's because it's a duct dependent lesion. So usually the functional closure happens in 24 hours. So they may present after the second day, they can present with this.
So the reason is the duct closure. So
That closer, yeah.
how do you manage this child? Now this child is in distress, low sats, and there is a murmur heard. So how do you manage this child?
Yeah, initial acute management, emergency management needed for this child. First is airway, breathing, circulation. We have to see. So needs
Okay.
oxygen, because it may close faster. Also, we have to
So we
consider
will give
immediately the
oxygen in
prostaglandin
child,
infusion.
or what you
Yeah,
said, ABC, and then
prostaglandin infusion.
okay, oxygen will be given or not?
Actually, we can actually, but the chance is the PDA will close faster.
Mm.
Yeah.
So it will aggravate the problem.
Yeah. Yes.
Okay. So next.
Next is the multidisciplinary team involvement for this child, and that includes the already neonatologist will be involved, and the cardiologist for confirmation and further management of for this child.
Okay. For now, you started giving prostaglandin infusion. How do you want to monitor this child?
Yeah, because prostaglandin can cause hypotension. It can cause apnea. So
We will
continuous
just
monitoring should
continue
be
on
there.
for the sake of discussion. Okay.
Yeah, yeah.
Apnea. Can
Apnea,
you repeat again? How
hypotension,
do you
and
want to
also
monitor this child?
hypoglycemia or hyperglycemia. Something sugar also should be monitored for this.
So prostaglandin will cause apnea. So you want to monitor him, right? Apart from
Yes.
that,
Apart from that, can have hypotension.
hypotension. Okay, you said airway, breathing, circulation, oxygen, prostaglandin. Apart from that, what you will do for this baby?
For this baby, IV fluid should be started because poor feeding is continuing. So IV fluid, electrolyte and blood sugar should be managed for the newborn baby if any abnormality associated with. And any hypothermia or hyperthermia should be managed day to old child baby. Along with that, if sepsis workup positive, then we'll start antibiotic for this child. And we'll do the investigations. No, investigations includes complete blood count, blood sugar, electrolytes, and for this child, echocardiography and maybe ECG.
You will do the septic workup
Septic
or
workup
not?
also, yeah.
Yes. We'll do the complete septic.
Yeah, CBC, CRP blood cultures,
urine analysis.
procalcitonin, urine analysis. Yeah.
So how do you know that you started prostaglandin, and how do you know that this baby is improving?
Okay.
This baby is responding to your treatment.
Yeah. Maybe the saturation will improve and child activity also improve if it is working. But yeah.
Okay.
And the distress also will reduce.
Okay. So what are the things in the examination, in your examination, which is favoring this diagnosis of you said sepsis? So can you tell me what are the things in you said the number one topmost is sepsis. So I want to ask in the history and examination, which is
any newborn child who presents with like poor feeding, lethargy, not inactive, with respiratory distress, with tachypnea, we have to suspect sepsis. But anyway, here if it is femoral is there, obviously we will keep the possibility of coarctation of aorta. One of the actually in this case simultaneously we have to do all the workup, and one by one, once rule out, accordingly we have to treat.
Okay, when we take pneumonia as the diagnosis, what signs and what from the history and the science is not suggesting pneumonia here?
Yeah, because there is pneumonia here because the chest is clear, There is no just like crepitations or rhonchi in the chest. Only thing fitting is the respiratory distress this child is having, and yeah, and also no upper respiratory symptoms.
Okay, I am
No
done.
cough.
Okay, I am done. I will give my comments, but before that, I want to ask others if any questions you want to ask, if you think that can be asked in the exam for this case.
I will tell some. I forgot to ask about the birth. I might have asked like maybe I don't know whether significant or not. Term, preterm, I didn't ask. And the
You
mode
have
of
to
delivery.
ask. Term preterm is very important, but he is
Yeah.
3.75 kg.
Yeah. Then I
Weighing,
got the clue that he's okay. Yeah. And you
Hmm.
told about 36 weeks there is scanning and all. So almost near term.
Yeah. So somewhere you will catch it, but asking is better. Direct question is better.
Yes.
It will not be missed. So anyone wants to add to the questions to the candidate before we give the feedback?
Duration of admission and follow-up. And how you will follow up with the child.
Okay. Follow up with the child. Now child needs admission and acute management and maybe needed shifted to the cardiologist.
You will
or
tell the
cardiothoracic surgeon.
No.
And
You will refer him to the tertiary center. Now he will be shifted to the tertiary center for the cardiac management.
Yes.
But before that, you will, in your hospital setup, you will involve the consultant because this child is serious. Okay.
Yeah, neonatologist involved already.
Yeah,
no? He's the one who will be involved.
Neonatologist, pediatric cardiologist, and your consultant. These three will come here main role because you want to admit the baby in NICU, start on the prostaglandin, and has to be monitored for apnea. And you have to check for the improvement. Once the baby is stabilized, and by the echo, if it is proved that it is coarctation of aorta, you will immediately transfer the baby to the tertiary cardiac center for further management. Okay, but our role comes here mainly in the emergency management here. Okay, which is the ABC, and involving the neonatologist, involving the consultant, sending the labs for all septic workup, and doing the echocardiology. And these three multidisciplinary team has to be involved at the moment. That is the neonatologist, pediatric cardiologist, and the pediatrician. After stabilizing the baby, you will refer to the tertiary cardiac center. This is the final management. Okay, anyone wants to add anything?
Hello, I have a question. Is the diagnosis coarctation okay, aorta? Because from the history, I'm thinking it's more of TGA because of the age of the baby. And then also because of the...
TGA will be sinussed, maybe.
No, this is
not
coarctation.
TGA will be sinussed. If there is no
transposition of great arteries, no. This is more history going with coarctation. I will give
this is a clear history of coarctation, because she told murmur and she told the pulses, femoral pulses is not there. Dr. Noor, I want to ask one question. If you give her like clear picture of femoral pulses is not there, murmur is there, goes to the diagnosis of congenital heart disease, shall I present first of diagnosis should be cardiac here, second sepsis, or I will still say the sepsis first?
No. Congenital heart disease should be your first diagnosis.
First diagnosis because I have
wait. What you are giving diagnosis is not here by your investigations and the echo. You are giving it by your history and the examination. By your history and examination, the child has no fever. She asked for fever. I said no. She asked for cough. I said no. She asked for nasal block. I said no.
So it should be first should be congenital heart disease, right?
Pee and poo was asked. I said no. So even though sepsis, see, it's not a rule in a neonate that the fever should be there for the sepsis. It's not a rule because neonatal presentation
they will not have fever,
but still the femoral pulses not palpable, if it is sepsis or septic shock, all the pulses should be bounding, or all everywhere it should be. There is a clear discrepancy here.
Yes.
It will be uniform. But here it's a clear discrepancy that there is brachial, but there is no femoral. And so congenital heart disease here is top than the
yeah, this
sepsis.
is what was my doubt, that I should first say here cardiac rather than the sepsis.
Yeah, you can tell cardiac, and also you can tell coarctation of aorta, because you will support your diagnosis by the femoral pulses.
Yeah, congenital heart disease most likely coarctation. Second will go to the sepsis.
Yes, because there are 4 left heart outflow tract obstructions which will present at this age. Anyone can name us? I have muted all. I am sorry. I just
left heart syndrome.
Left hypoplastic heart syndrome, coarctation, severe coarctation.
Then another 2.
Critical aortic stenosis.
SRT, truncus.
Truncus.
There are 4 left. So one is hypoplastic left heart syndrome. Second is coarctation of aorta, severe critical aortic stenosis. One more.
Pulmonary stenosis.
No.
That is not.
I am telling left heart, not right.
That is right side.
Left outflow tract obstruction.
Interrupted aortic arch.
Yes, interruption of the aortic arch. In which condition we see interruption of aortic arch more commonly?
I think you see it in Turner.
DeGeorge, right?
DeGeorge, I told you DeGeorge.
DeGeorge, you can see interruption of aortic arch, but a rare presentation, you can see it. So even a DeGeorge baby can come with 2 in the second day presenting like this because of the interruption of aortic arch. So I will give the feedback to Dr. Sri Devi now.
What is the cause of murmur in second left space?
Wait, what?
What is the cause of the murmur on the second left space?
When I give you the feedback, you will get to know, everything will be covered there. So when you are, your history was okay. Here the history is like acute history. So the social history and all is not much needed, but still you can. Okay, so when you go for the step-by-step exam in the history, again, exploring the whole birth history is very important. You asked about the pregnancy, it is good, for which she told you that only once she was admitted and IV fluids were given. Then the detailed birth history. In the history, you did not ask about the birth weight and the term baby. It is very important here. Okay, this was missed. You are here, right, Dr. Sri Devi? Hello. Okay, term baby birth weight was missed here in the history. This is very important. And also when you ask in the clinical examination, you should also, even though in the history you got to know that the child is unwell, but still you have to ask to the examiner when you are asking the question whether the child is looking well or unwell. Okay, you should keep on, you should start asking in the cardiovascular system. You will ask whether the child is well or unwell, and about the dysmorphic features, which she asked about the dysmorphic features, which we were telling 5 Ds, all has to be covered, like distress, baby is well or unwell, and dysmorphism. Okay, disability I don't think here is needed. It's in the 2-day-old baby. Okay, and cyanosis, asking about the cyanosis she asked about it. And one thing she missed was she asked swelling anywhere in the body. It's more than swelling in a cardiac case. What is more important? Can anyone tell?
Edema.
Edema is more important. Yes. Instead of asking as swelling, she asked about swelling. I put here the circle for her. She should ask edema. It is more important, and edema has to be checked. Okay. Edema, and or you can ask, is the baby looking puffy also? Because the right heart failure, you may have the swelling in the feet, and also overall edema, because this is a small baby, and you also have hepatomegaly here. Okay, next, vitals. She left some parts in the vitals. When she asks the vitals, she covered mainly the pulse, where the femoral pulse came, and I told her. Once I gave her femoral pulse, she went to 4-limb BP. That is good, but in the vitals, she has to ask everything, like about the temperature, pulse, BP. Only pulse and BP and O2 sat was asked. She did not ask about temperature and capillary refill time. Okay, capillary refill time. So what she missed here was RR, but RR was given in the they will give you, but still when you are talking to the examiner, you have to ask about complete vitals, that is temperature, pulse, blood pressure, O2 sat, RR, and capillary refill time is very important because the baby is just 2 days old. Okay, so if you would have asked, I would have told temperature is 37.4 and heart rate is 160 beats per minute. Brachial pulse is palpable, but she asked for radial delay, which is good. I said no, but the femoral pulse is difficult to palpate on both the sides. Then pressure.
Excuse me, can I ask a question? For this radial delay, can we see radial delay in a newborn, because radial pulse palpable in to palpate is very difficult.
Yeah, you're right. She asked for radial delay, but we have to check brachial pulse on both the sides. Okay. Brachial pulse has to be checked on both the sides. Okay. And but normally when we are doing any other cardiovascular station, we will talk about the radial delay and radiofemoral delay. So when the pulse comes, we should not forget this. We have to cover both these aspects so that we will not forget about the femoral pulse. Okay, femoral pulse is difficult to feel. She covered this. Then 4-limb blood pressure. She told she'll do in the last, but you can ask, because here 4-limb blood pressure is important. Once you got to know that the femoral pulse is difficult to feel, 4-limb blood pressure becomes an important topic here. So better to ask the examiner, because here there is no patient and you're not measuring it. And even in a normal exam, if there is a patient, they will not bring you a 2-day-old baby. Since now there is no patients, they are bringing such cases for you in the exam. So here you will ask for the 4-limb blood pressure. If you ask, I would have told her that in the right arm 70/40, in the left arm 75/45, then in the left leg 25/0, like this. Okay, I would have told there is discrepancy here. She told she will measure in the last. I just kept quiet. Then capillary refill time. She did not cover only. It is very important. Okay. And when in these cases, you should also ask about is the SpO2 checked in different places? Why is it important? Like in the arm and the leg, the SpO2.
You will have to see the preductal and postductal saturation.
Yes, preductal and postductal. So preductal, if you check in the right arm, it is 89%, and postductal, you're not able to pick up. You're not getting the reading. Okay. If she would have asked, I would have told, because vitals here is more important. Then in the inspection, there is nothing except the intercostal recessions. Then palpation of apical pulse. If you tell something, they may ask you also how you do it. Tell us. Okay. So you will tell that you will put your hand and where you feel the maximum impulse, you will put the finger and check. Okay, and I want to ask, this is a 2-day-old baby. Is the 5th intercostal space mid-clavicular line is the right position, or it is, what do you think?
What is the question?
Oh,
What's the question, Dr. Noor?
5th intercostal space, mid-clavicular line. Is it a right or it is enlarged heart? This is my question.
It should be in the fourth intercostal space in newborn.
Fourth
Yeah?
in the newborn.
What?
Fourth intercostal space in the newborn.
Normally, it is present medial to the mid-clavicular line. Medial to the mid-clavicular line.
No, in this baby, I'm telling it is in the 5th intercostal space, mid-clavicular line. Is this heart enlarged or it is normal? This is my question.
Enlarged.
Enlarged.
So normally, what is the position? It is 4th intercostal space?
Yes.
Yes, and medial to the mid-clavicular line.
That means that this, if they tell you, it shows that it is enlarged. Next, what she left was, even though he is newborn, you should ask about, you will keep your palm on the left sternal border and check for parasternal heave. Okay. Then thrill is there, auscultation is there. Sorry, it went out of my mind that we missed our prayer. So we will take 10 minutes break and we will come back. I am sorry. Actually, I forgot. Okay.
I think Dr. Noor, thrill is, we can identify by both palpation and auscultation. Palpation by the 2 fingers. 2 fingers in 4 area, like mitral, tricuspid, aortic, and pulmonary. And auscultation also in 4 area, because thrill means 4, murmur grading 4. This is thrill. Up to 3 is not thrill. More than 3, that is 4. Grade 4 is thrill. Yeah, 4, 5.
4 hours.
Okay, tell the positions now. Mitral area.
Tricuspid area. Mitral area is apex.
Okay.
Tricuspid area is the left 4th intercostal space. Then aortic area is the right 2nd intercostal space, and pulmonary area is the left 2nd intercostal space. And this intercostal space actually not at the lateral border, just not at the lateral border. It is a little bit away from the lateral border of the sternum. So if you locate at the lateral border of the sternum, it is not the exact location. Exact location is 2.5 centimeter away from the sternal border.
Okay.
So this is one important. So thrill means actually it is a part of palpation and auscultation. So we will palpate first by the 2 fingers in the 4 area. Then we will do auscultation in the 4 area.
In this child, there were no thrills, so only murmur. Okay. But the radiation of murmur was missed by the candidate here. I gave her the clue also. Where else you want to auscultate? She missed telling that she will auscultate the back in between the scapula.
Yeah.
The murmur.
PS murmur, yeah, that radiate to the back. And the left-sided infraclavicular area is very important. That is for the murmur of location of PDA. And thrill, aortic thrill is in the mainly on the right side carotid artery, but also in the left side carotid artery, you can feel thrill sometimes. Mainly in the left carotid, actually, left side of the neck. That is the exact location of carotid thrill or bruit, you can say.
So for
these are the
for the auscultation, along with the normal 4 auscultation areas, you should also tell for the radiation. You will check in the axilla, you will auscultate the axilla also.
the
Radiation of mitral murmurs and the back. Okay, even the murmur of coarctation of aorta will be heard at the back. Right?
Yes,
in the shoulder blades.
But remember that every murmur radiation is not same. So if you find mitral murmur, don't see the neck, don't see the back, see the apex, so that examiner doesn't get confused that what you are checking actually. So according to your murmur, what is the type of murmur? Is it systolic or diastolic? Is it continuous or it is early? That is
auscultate the axilla or the back, whatever you want to auscultate.
Yeah. So don't do everything in every patient. So do according to your finding.
Yeah, these are the things she missed. Otherwise, she covered the lung sounds, she covered the liver. Okay, she was asking for spleen, but I don't think we will go for spleen in cardiovascular examination. You will check the liver just for the heart failure.
You will go, you will go, because sometimes some infective endocarditis, only there is splenomegaly, there is no peripheral signs, because peripheral signs are rare nowadays.
But not in this age, 2 days, 2 days
but
old.
2 days old child, you will expect the infection endocarditis with no fever and
I miss
normally,
the scenario.
Normally, as I have read the structure of cardiovascular examination, we will check for the peripheral signs of the infective endocarditis, like in the hands, any splinter hemorrhages and Janeway's lesions, osseous nodes like this. But I don't remember in the scheme telling about splenomegaly palpate for infective endocarditis.
There is an examiner,
if we see the peripheral signs, then we will go for it, right?
No,
or
actually there is an Indian examiner, okay, in some years back, and a candidate missed the spleen. He said the peripheral sign, osseous node, Janeway lesion, splinter hemorrhage, but he missed the spleen. So the Indian examiner actually was not very happy. He said that splenomegaly is the occult sign of infective endocarditis that is not seen from outside.
Okay. This he was in UK or in India?
No, examiner was Indian, but actually in India, Bangladesh, we see many infective endocarditis. We have tendency of infection. So
no, this comment was in MRCPCH exam. This is my question. And it was in UK or what?
No, it was in which country, I don't know. But the candidate feedback. The candidate feedback is that I did not tell about the splenic enlargement, and the Indian examiner was not happy.
Okay.
This is the feedback from the candidate.
Should we do spleen in the newborn?
No.
Not in the newborn.
Not in the newborn.
So in the differential diagnosis, the topmost will be coarctation of aorta. What are your supporting findings? Were the absent femoral pulses, okay, and there was hepatomegaly. But I want to ask, normally in a newborn, now in this child I told 3 centimeters below costal margin. Normally in a newborn, how much is acceptable below the costal margin?
Just palpable. Below 2 centimeters, not 3 centimeters.
This 3 centimeter means it is hepatomegaly.
Yeah, okay. Enlarged.
And other things which are supporting is again the apical impulse. It is in the 5th intercostal space, mid clavicular line. Okay.
Yeah.
This is also one of the supportive point here. and hepatomegaly and absent femoral pulses. This is more important. The second, yes.
And the blood pressure. Blood pressure will be different in coarctation.
Yeah, blood pressure was checked, and I told that in the upper limb it was 70/40, and in the lower limb it was 25/0. Okay.
Another is differential cyanosis, differential blood pressure, difference in pulse, difference in saturation. There are 4 differences in coarctation.
Yes, you are right. Difference in pulse, difference in saturation, difference in temperature, and difference in blood pressure.
Cyanosis also. There may be cyanotic lower limb.
Yeah, can be. Then the second differential you can put is the infection or sepsis. Okay, the reason is the poor peripheral perfusion, but you can tell less likely because here again you don't have the features of fever or no other things suggesting it. And for pneumonia, as we said, the breath sounds were normal, so it was not suggestive. So the points which are going in favor of coarctation of aorta, here is there is a systolic murmur and hepatomegaly and a large heart with apex palpable in the 5th intercostal space mid-clavicular line. Okay. Other differential you can put is the inborn error of metabolism in this child.
Sepsis is first always. Remember, in a neonate who is sick, before telling congenital heart disease, say sepsis.
But here in this situation where the brachial pulse is very clear and femoral pulse are not palpable, 2 days old, suddenly deteriorated, no fever, I know sepsis you have to put, but when the signs are very clear, you can put congenital heart disease as the top because you also have a murmur.
Yeah, right. But in the examination, you will say like that I have in my mind that it can be a case of sepsis, but the absence of femoral pulse and the presence of brachial pulse rules out the sepsis. So I put my differential diagnosis, sepsis at 2nd. And metabolic disorder is always on the 3rd because metabolic disease is not so common.
Yeah. All right. And in the management, we will say that we will first stabilize the baby, as we all know that the baby is in respiratory distress, unwell, the saturation is 89. Okay. So you will first stabilize the baby. You will check for the airway breathing circulation. You will, about the oxygen I was asking.
Yes, first of all, before diagnosis, you will give oxygen. Then it will fail to improve. This is hyperoxic test. It will fail to improve.
Oh, see, this child, wait 1 minute. This child is coarctation of aorta. Suppose this child is coarctation of aorta, and the cause for deterioration is the duct closure, beginning of the duct closure. Okay.
Yeah.
So you will give oxygen or not? This is my question now.
Yeah, you will give. You will give. Then after oxygen, if the child's saturation is not improved, that means hyperoxic test is failed, negative. That means it is a congenital heart disease. Now you see it is a duct dependent or duct independent. There are 2 kinds of lesion. Okay. Then you think it is a duct dependent. Then after stabilizing A, B, C, you have to restore the circulation. Oxygen is continued, and A, B, you will gradually slow down the oxygen, and then you will give prostaglandin. Prostaglandin, even without echo, you can give because it is a life-saving.
Suspecting.
Yes, and hyperoxic test is negative. Also, you can do nitrogen washout. Both will be negative. I mean, this test, the baby's saturation will not improve. So the confirm it is a congenital heart disease. Now, which variety? You are suspecting it is a obstructive variety because, now obstructive variety is also 2 types, like left-sided obstructive and right-sided obstructive. So you are suspecting it is a left-sided obstructive because the baby collapsed.
Yes.
Okay, collapsed, ash color. So this is left-sided obstruction. In right-sided obstruction, baby doesn't collapse. Baby present with cyanosis, like pulmonary stenosis. Baby present with cyanosis. But in left-sided, the baby will be collapsed because of hypoperfusion. It is a drug-dependent systemic circulation. So you have to give prostaglandin in either way, either right side or left side. You have to give prostaglandin. And in the district general hospital, you don't have echo, but you have to do prostaglandin infusion. And dramatic improvement of saturation after prostaglandin infusion is the diagnosis that this child had drug-dependent lesion.
So see, the main questions of the examiner here will be, you are giving prostaglandin, how you will monitor the child? This will be asked.
Yeah,
okay.
Management of side effect, hypotension, bradycardia, apnea.
Hypotension, bradycardia, apnea. So for this, you will keep the child definitely in NICU for cardiorespiratory monitoring. You can tell only one word like this. The child will be admitted to the neonatal intensive care unit for cardiorespiratory monitoring, to give the prostaglandin and cardiorespiratory monitoring under the care of neonatologist. Okay. This will be the best answer here. And next, depending upon the deterioration of the baby, he may need ventilation. So for this purpose, you will be monitoring the cardiorespiratory monitoring will be continuous while you are giving the prostaglandin, and it will be in the neonatal intensive care unit under care of neonatologist. Okay.
And of course, contact with the cardiologist and urgent referral. Arrange urgent referral.
Yeah, contact the cardiologist for urgent echo, and once the baby is stabilized with the prostaglandin, and this will be asked to you. How do you think that your treatment management is working? So you will say that the saturations of the baby is improving, and chest recession will improve, and BP will improve, and all the 4 parameters what we discussed, like the pulse, difference in pulse, that will improve, difference in blood pressure will improve, temperatures will improve, chest recession will improve, saturations will improve. So you will see the improvement in the baby. That means he is responding to prostaglandin. Once you see this improvement, you will refer the baby to tertiary care center for operation, tertiary cardiac center. Okay. So regarding the investigations, even though your top here will be the congenital heart disease, you will not leave the septic workup. The baby has to be worked out for septic workup. So for investigations, you will tell that after telling the ABC, and you will put on the oxygen. And since you see no improvement, you will plan for the prostaglandin infusion. So you will involve your consultant and the neonatologist, and also the pediatric cardiologist to perform the urgent echo. Then you will you will say that the IV cannulation, and you will draw bloods for septic workup. You can tell like this, and you can tell what is that: CBC, CRP, blood culture and sensitivity, urine analysis culture and sensitivity. Okay, and even you can tell the chest X-ray also, because this is a neonate, you want to rule out everything. Okay. So complete after this septic workup, you will go with the prostaglandin and other things. And what about the antibiotics? Because since you will start your diagnosis, still you will start the empirical antibiotics.
Empirical antibiotics after septic workup.
No, okay. After drawing the blood, you will start, or you will wait for the results? This is my question.
You will start. You will start.
Okay, that means we can also say here empirical antibiotics will be started. Now here we have put
you have suspicious of sepsis, so you will take the blood cultures and other septic workup. So you will start empirical.
Okay. But I don't think in this child we will go to the extent of the lumbar puncture till we get the results, and when our top diagnosis is PhD, right?
Septic workup in neonates include lumbar puncture.
Yeah, I know that, but still you will go in this baby.
Yes, you will go any baby who is neonatal period presenting sepsis, suspected sepsis, you will do. because you are starting empirical antibiotics, you are doing septic workup. So most of them they do, because we see the neonates they do. But if it is like, suppose in our NICU, when I see the patient, they don't start for those who are already inpatient, but who comes from the home, they do for them.
What do you mean by already inpatient? When they were
Like
admitted, they were
suppose,
not done.
one baby they call us that he deteriorated, he had a respiratory distress, and to rule out cardiac or rule out sepsis, because he is already there and they know the patient. But the one who comes from home, for them sometimes they don't do LP, but who are for the one who comes from home, they do for them LP. The one who is already there, and you resuscitate the baby, and you saw the patient already, he's clean, they don't go for sometimes they don't do LP for them, but mostly they do.
Okay.
You mean inborn and outborn babies, no?
But we can
The
still
babies.
yes, sorry, Dr.
Uh,
Balal, yeah, you can go
Yeah,
on.
yeah, I think you mean inborn and outborn babies. Inborn babies which are born in the hospital there, and
Yes,
babies we
yes,
are outborn. Yeah, you mean to say that? Yes.
yes. The one, suppose I got call from the NICU, patient is deteriorated, rule out sepsis and cardiac. This patient, you are having already there, the patient, he's clean. The one who comes from home with like this sepsis suspicious, and to rule out both sepsis and cardiac, for them they do.
Okay. Anyways, our
Because
main
because we see a lot of patients like this who comes like one day, second day or third day of life. Most of the time ER is asking, shall we go for LP? Shall we go for LP? Because the patient coming from home, you are suspecting the sepsis here. So
Here
at that time
baby, here baby was very sick, so we won't be doing LP.
that is different thing. If baby is very sick, that is different thing. You have to see 1, 2, 3 that time.
Okay, so Dr. Sridevi asked about the history of cough and sweating from mother. So I want to know, do we ask about history of cough and sweating if we are suspecting congenital cardiac heart disease in a 2-day-old baby?
She just asked as a systemic review. Cough can be asked, but sweating, I'm not sure. Maybe
2-day-old baby don't cough, and sweating is not seen in newborn period. So we won't be, even if we are suspecting of congenital cardiac heart disease, then also we won't be asking about history of coughing or sweating if a baby comes to you in newborn period.
Yes.
And one investigation which we also should send is, and that is serum ammonia levels. Because if our third differential is metabolic disorders, then we have to rule out, because many metabolic disorders present with congenital cardiac heart disease as an association. So first investigation will be echo, second will be septic screen, and third will be serum ammonia levels to rule out metabolic disorders. And blood gases, ABG.
For the LP, you people are discussing, if the patient is delivered in the same hospital and he was in the hospital, then you will have to take the history from the mother, I mean to say antenatal history. If there was history of premature rupture of membrane or the fever during the labor or 24 hours before the labor. So this is, if the child has been discharged and he is coming back after 2 days, then you will have to decide for the LP definitely, because he's
Yes.
coming from
Yeah,
outside.
this is what doctor I mean, that if inpatient,
Yeah.
you have to rule out from history. If outside,
only.
coming from outside, you have to do full
You have
septum.
to do. Yeah,
You
this
have
is
to
this
do.
is the
No
protocol
choice for
actually.
that.
We are keeping in neonatology.
Yes,
In
yes.
IC.
Same thing we follow in our hospital, that
Yeah, if delivered in the same hospital and he was in if the mother is having history of premature rupture of it,
chorioamnitis fever during fever
even
during
the previous history of colonization of GBS,
yes,
the
yes.
mother, then you will have
Previous baby infected with GBS. Yes, you are right.
yes, then you will have to do.
Yeah.
Otherwise, no need.
Also, I remember that if the baby has positive septicemia, for example, gram-negative sepsis, they
Gram negative, you must. Gram
should
negative,
be
you
done.
must.
Yes, will be
Gram
sick
negative, you
baby or
must.
positive blood culture. It's required to do. Will be.
Gram negative, you must do the
Yes, yes.
Yes. Regarding in the history, yes, 2 days old baby, there will be no sweating and no cough will be there. You should ask particular question while the baby is feeding. He's having difficulty in feeding or not. Like maybe there is getting this respiratory distress or distress, you can say, just while you are asking from the mother. So this will be there, but there will be no sweating or cough.
When? Huh?
Performa in the extended
What
clinical
should,
exam.
what is
Performa
the
like
question?
yeah, what should we adopt to take the history? Like just a presenting complaint, history of presenting illness, and then antenatal or postnatal. But I mean to say, yeah, we are using some performa in doing the normal history, presenting complaint, then history of presenting illness, then systemic inquiry, then past history, the other things. But for the extended clinical, what should we adopt for that? If anybody has some kind of good performer, or he may make some notes or something like this, like in the normal history. But here we will not take the normal history. This is just an extended clinical and short period of time, just for 10 minutes. So there should be a kind of performer, like we will ask about the history of presenting illness, a little bit past history if the child is old enough, and about like newborn baby. We'll have to ask about the natal history, antenatal history, or something like this. So what kind of performer we should adopt?
See,
Because this is
actually,
completely new for us.
yeah, everything depends again upon your case. So for example, if we take this case, your main concentration here, the main complaint is the poor feeding and pale. So you will take completely about the feeding history, how is he feeding, any vomiting, any diarrhea, because the child, it's a small child. So after the main complaint here, the perinatal history becomes very important here, including the pregnancy, natal and postnatal. So you explore that. Regarding the family history, when you doubt about the cardiac, you can ask just as the thing. And social, again, I don't think here the social plays a very important role, because
Yeah,
it's
this is
just the
new.
acute presentation. And you can just, if you want, you can just ask about the financial issues. But as such, this is acute presentation and first presentation. I don't think it plays a much important role. So you will select your history here accordingly. And sometimes it's not necessary that you will take the whole time. Even if you finish early, they will continue you with the summary and other things. But once you say that you finish the history and the role player is gone, you cannot ask any more questions. This is what they have told you. So if you want to use your whole 10 minutes, you can use just asking. And lastly, you have to ask this question, like anything which I left, because mother knows most of the things. Maybe she's hiding something from you. And if you ask this question, maybe she will give you. So anything which you think which is important, which I did not ask, this becomes very important. But still, I think we have to make a format. Again, it depends upon whether the child is acute presentation or chronic presentation. If they give you any chronic case, the family history, social history becomes very important here, and you have to explore that more.
Yes, yes.
Yeah.
Yes, definitely.
So
Because in the last exam, it came, I think maybe 8 years old or something like this, and GBS patient. So there will be a different format we'll have to take.
What GBS came?
Yeah, GBS came for extended clinical. Guillain-Barré syndrome.
They can ask anything in the extended clinic because there is no patient. It can be a serious case, it can be a chronic case, normal case, anything.
Anything, yeah, they can ask. So what I was thinking that we should make a format at least.
Yeah. But now again I am confused because they are telling that in the face-to-face exam there won't be any extended clinical.
Yes, there will not be extended clinical. Yeah, for you and other people who are in Saudi, they can take this benefit. But for us, no. We'll have to take online only. We cannot travel. So we'll have to.
Now, I just now received some messages that they are telling Sudan also they will make face-to-face.
Ah, that's good.
Slowly they are changing.
Good.
Okay. Yeah, go ahead.
No, I'm thinking, yeah, that's good. At least maybe Sudan will allow us to travel because Saudi is not we cannot travel in UAE. We cannot travel, so this is difficult for us. So
yeah.
it will hopefully it will be good. So, yes.
Okay, so this was the case. This what we discussed also is a case from here, from this book. This is the illustrated textbook of pediatrics. A 2-day-old baby has been discharged home the day after delivery following normal routine examination. This is very important. The baby was discharged after normal routine examination. He suddenly collapsed and was rushed to the hospital. He was pale with gray lips. The right brachial pulse could just be felt, and the femoral pulses were impalpable, and his liver was significantly enlarged. Blood gases show a severe metabolic acidosis. See, in our labs, we did not tell about blood gases. It is one of the important investigations here. Okay. So don't forget about this. The brachial pulse is palpable, but the femoral pulses are impalpable. But still, even that is just could be felt. Liver was enlarged. Blood gases show severe metabolic acidosis. The differential diagnosis here, they put congenital heart disease, septicemia, inborn error of metabolism. But in the case I presented, I told you that
You told about the saturation is 89. Rather than, I don't think so. They will give you like this. The saturation will low like 89. This is low for the newborn, especially. They will give you acidosis. So here we will do the ABGs for lactate level, not only for oxygen. Lactate level and pH level.
Yeah, so ABG is important, which we did not tell
Yeah,
when we were discussing. This is what I said.
maybe I could not listen.
Yeah, he was ventilated and treated with volume support. So volume support is important here. Blood cultures were taken. Antibiotics started for possible sepsis. So even no need to wait for the results. You will take the blood cultures for the septic workup and you will start the antibiotics. Blood and urine samples were taken for amino acid screen and urine for organic acid. So as Dr. Manish said, we will cover all our differential diagnosis. So for the congenital heart disease to diagnose, you will do the urgent echo. For septicemia, you will take all the laboratory investigations needed for sepsis. And for the inborn errors of metabolism, you will take blood and urine samples for amino acid screen. Okay. And urine for organic acids. So blood and urine for amino acid and urine for organic acid. As femoral pulses remained impalpable, prostaglandin infusion was started. Within 2 hours, he was pink and well perfused and acidosis was resolving. Severe coarctation of aorta was diagnosed on echocardiography. He had developed shock from left heart outflow tract obstruction once the atrial duct was closed. Okay, so this was our case.